You are now watching Martin's Minutes, hosted by MAG President Dr. Deborah Martin, sponsored by Medical Association of Georgia.
Thank you all for joining us tonight. It truly is a unique year down at the Capitol. It is an election year, so the focus is on affordability, lowering taxes. The House and the Senate have dueling proposals to lower your taxes, which include reduction in property taxes, as well as potentially eliminating the state income tax. Underneath the affordability push, we are seeing a lot of focus on rural health and expanding access. Expanding access, we of course support. However, underneath that is a number of scope of practice bills. We have scope of practice bills for chiropractic physicians to change the state law there. We have expanded prescribing by PAs and APRNs, which would put up to 10,000 more prescribers of stimulants, opioids, and Schedule II drugs out on the street, which we are certainly concerned about. And we're also seeing a number of bills related to podiatry and podiatry having mid-levels that they supervise. We also have a ketamine bill that we are attempting to put some regulation on ketamine, given it is completely unregulated here in Georgia. So a very different legislative session from last year when we had a focus on tort reform and a significant victory there. It is more of a series of little fires that we're working to put out to ensure that the patient-physician relationship stays protected by Georgia law. I'd like to introduce our general counsel today. We apologize for those of you who were at the COL call that we scheduled and unfortunately had to cancel. Legislative hearings on the appropriations budget for health lasted far longer than we expected and were delayed. Brent, would you like to talk a little bit in more detail about our major focus items as well as any other items at the Capitol or at the Supreme Court?
Hi, and I apologize for interrupting. Everybody, if you're not speaking and you might have back noise or other people talking, if you could go ahead and mute, that'd be wonderful. Thank you so much.
Well, hopefully everybody can hear me. I had to figure out how to unmute myself. I am the lawyer, not the IT professional, and I'm having some issues with my camera. So you'll just have to look at my much younger headshot. Sorry. Building off what Jeremy said, absolutely. This has not been a year for a marquee issue at the legislature like last year's tort reform initiative or CON or other things that we've had in the past. But it is certainly, if there's a theme to the year, it is brush fires. This will probably be the year of scope expansions, or at least scope expansion attempts. But leading off in a sort of a different vein, building off what Jeremy said, I mean, just 2 hours ago, we were testifying before the House Appropriations Subcommittee on Health on two issues that are important for the medical community here in the state of Georgia. The first that we've been supporting is the heart-lung transplant for adults to get Medicaid coverage there. And we have been advocating for an extended coverage for our rural safe haven program, where we've covered about 1,700 physicians practicing in rural areas to prevent burnout. The other issue that we are supporting actively that Jeremy mentioned is an addition to our tort reform measures last year. Representative Matt Reeves has worked together very closely with us, and he has introduced a homestead protection bill for healthcare professionals, which, if passed, would mean that your primary residence is protected from any malpractice claims if you were to get a judgment against you. And we strongly support that. That's part of our multi-year initiative to continue to press on medical liability reforms within the state of Georgia, actively supporting that. Another piece of legislation that we are positively supporting is the ketamine clinic regulation. We've had quite a few discussions at the Capitol, And with a composite medical board, and there really is an alarming trend throughout the state of Georgia where we are beginning to see a lot of folks open up for profit cash pay clinics that administer intravenous ketamine and really without appropriate oversight. The conditions that we're observing are wildly dangerous. So, the bill itself is to promote physician oversight, registration, allow the composite medical board to do that, and investigate and examine these facilities, and really so we can begin to quantify what the issue is. And we're being proactive so that we can avoid issues that were similar to the opioid crisis, because not far behind this off-label use of ketamine for mental health treatment, FDA's in trials for things like MDMA and LSD, which the chances of diversion and the misapplication or mismanagement of patients that are receiving those treatments is profound. So we really are trying to proactively get ahead. And then, of course, the traditional float of bills where everybody wants to be a doctor, but nobody wants to go to medical school. Podiatrists are seeking to be able to oversee physicians' assistants and be primary supervising authorities there. And chiropractors would like to be known as physicians. Obviously, we are strongly opposing these bills. We have several other issues, particularly surrounding mid-level prescribing. There's a couple of bills about allowing nurse practitioners and physicians' assistants to prescribe Schedule II drugs and stimulants, and we are working to oppose those bills as well. If there are any questions, I'm happy to entertain them. I understand, based on a flurry of text, that our special guest has joined us for the evening as well. So thank you, everyone.
And everyone, right before Dr. Martin and Van begin, if you have any questions during their discussion, please put them in the chat and we'll come right back to them once they're done. Other than that, though, Dr. Martin and Van, take it away.
Good evening. I'm Deborah Martin. I'm president of the Medical Association of Georgia. And this is a first of our Martin's Minutes, and I want to have a special guest tonight, Mr. Van Loskoski. He's a transformative healthcare leader. He's the CEO at Stevens County Hospital in Toccoa, Georgia. He started his undergraduate work as an engineer at Georgia Tech, went on to do graduate work in microbiology, medical microbiology, and he works now in rural health care, and he has a track record of trying to increase access to care, all kinds of things that he's trying to do. And Van, we'll let you tell them a little bit. How did you get from being a Georgia Tech engineer to the CEO of a rural hospital?
Probably a series of very bad decisions, but in summary, yeah, I was introduced to healthcare through a personal experience, and ended up for an extended period of time as a patient at Mayo Clinic in Jacksonville, developing juvenile myoclonic epilepsy at the ripe young age of 23, and I fell in love with what I saw happening around me. And at that time, I was a structural engineer in Atlanta. Loved what I saw happening in healthcare, felt more called to be a part of that world than the engineering world. And I did. I completely changed career paths, decided that the best way to be a part of that world is to become a physician. I had some bridges to cross in terms of my undergraduate degree and what that didn't prepare me for medical school, and got a master's degree in medical microbiology, and actually fell in love with population health and analytics while I was there, and chose a different career path in medicine as I became more familiar with it. And that has landed me through different jobs as a population health analyst, as a clinical practice administrator, and most recently, and for the last 5 years, as the CEO of Stevens County Hospital in Toccoa, Georgia. So that's how. Still always a little bit hazy on the why, but it was just the experience that I had working with physicians in a high performing facility.
Right. So I think all of us have some days when we wonder why, but healthcare is something that is very interesting and gets absorbs all your time. Can you tell us a little bit about Stevens County Hospital and the history and what it was like when you got there?
Sure. Yeah. So Stevens County Hospital, we're a 96 bed PPS hospital in the very northeast corner of Georgia. If you're not familiar with Toccoa, we're about as far north in the state as you can get without being in North Carolina or South Carolina. So if that gives you some idea of the geography there. Um, when I became the CEO in 2021, the hospital was in very dire financial straits and not an uncommon situation for many rural hospitals. What was different about this hospital was that it had been through several leadership changes in the 5 years before I came. I was the seventh CEO.
Uh,
Um, I tell my staff it's you kind of liken it to the captain of a ship. Like it's hard to get anywhere if the destination keeps changing and the captain decides where the ship's going to go. So I've now been there for 5 years, and we've been able to year over year increase revenue by at least 19%. And it's by opening doors to the hospital rather than closing them. Unfortunately, my very first day as CEO, I got to deliver the message that was a decision that had already been made, and that was that we were closing labor and delivery services. Um, Trial by fire, and it was a very tumultuous onboarding. I will say, as an insufferable data nerd, I have looked at the numbers, and yeah, for us, it was the right decision. The hospital was being anchored by that service line, which was losing at least $1.5 million per year. Um, we'll continue to crunch the numbers. I'm always going to expand service lines where it makes sense for us financially. The most important things for us stood out in our community health needs assessment, and that was that the leading causes of early mortality were cardiovascular disease, trauma, specifically motor vehicle accidents, and cerebrovascular disease, and a myriad of other things funnel into that. But we had no cardiologists, we had no trauma surgeons, we had no neurologists. So the three things that our community is telling us they need the most aren't being provided at their local hospital. So we are now a stroke center. We just yesterday dropped our application to become the state's newest emergency cardiac care center and are on our journey to level 3 trauma designation. And those are all things that were very important to me, both from the standpoint of the needs of the community, but also the perception of rural healthcare. And that's something that we're painfully aware of is that many rural hospitals are foreseen as the Band-Aid station, the transfer center. Um, but we've put things in place that really make a difference. Dr. Martin can attest to that because she performs surgery in our operating room. But I'm really glad to say that over the last 4 years, we've been able to cut our transfer rate by 67%, and now 97% of the patients brought to us by ambulance or arriving POV to our emergency department stay at our hospital for the entirety of their care. So we've become much more than what we were, and I'm always working to kind of change that narrative about what rural healthcare can be.
So that kind of leads into the title that we chose for this, talking about rural health transformation and Georgia's attempt to shift to value-based reimbursement. Can you just tell us a little bit what's going on with the rural health uh, in Georgia and why we decided to talk about this topic right now?
So you're going to hear a lot of interesting things coming out from DCH this year because last year in July, July 4th to be specific, House Resolution 1 was passed, the quote unquote One Big Beautiful Bill Act. For us in Georgia and states across the country, that represented the largest cut to the Medicaid program that our country has ever seen. But there is a component of that piece of legislation that is called the Rural Health Transformation Program. We've, as we do in medicine, abbreviated it. It's called the RHTP. And now Georgia's come up with a new abbreviation for their program, their application for that pool of funds, which is Great Health Program, GREAT, and I don't even recall what the acronym stands for at this point. It's become so dizzying to keep up with all the acronyms. We just know what it is, and that's that Georgia has been allocated $218 million this year out of that pool of funds to go towards advancing rural health care. That's pretty much the only description that was written into the legislation. The states get to decide a large portion of what that funding is going to be used for. In fact, the state gets to decide all of it. DCH has been handed off that pool of funds, or at least the access to the pool of funds. None of it's been drawn down yet. And so there's going to be a lot of discussion this year and for the next 5 years about where that pool of funds is going to go, because it's going to be somewhat similar to that amount of funding over the next 5 years. So something equating to nearly $1 billion that will be paid out to the state of Georgia. And it's becoming very nuanced as to what Georgia intends to do with that. And we've got some clarity to that now.
So Dr. Burke, as the director of DCH, is going to have to develop a plan as to what's going to happen to these funds, correct?
That's correct, and already has a general outline. There are still a lot of unknowns with what Georgia intends to do with that funding, but the outline is there at least, and you can go to their website and take a look at the application that they've submitted to CMS, and it's very lengthy. The budget is broken up into a few major categories, but there is one component of it, the majority component of it, is moving Georgia healthcare providers to a value-based reimbursement model, and another acronym, AHEAD, AHEAD, which is moving away from the fee-for-service model, where you get paid for every office visit and procedure you do, to a level funded flat payment that comes from CMS and specifically Medicare and Medicaid, but it's intended to be an all-payer model where commercial payers, or at least some commercial payers, are included within that bucket. So I, as a hospital, would get one flat rate, one flat payment from CMS every single month.
And that would have to cover all the people from Medicaid, or who would it be covering?
So Medicare and Medicaid for certain. What Stuart Portman will tell you and what Dr. Burke will tell you is that this is an all-payer model. The state doesn't have that much ability to overt change or inert change with private insurance companies, but they do with the state health benefit plan. So we expect that the state health benefit plan will get lumped into that bucket as well.
So how do you apply to get this money?
So there are specific things that the state intends to use that for. So I mentioned it's $218 million. 20 million of that is just in a line item called administration. We don't know exactly what that means, the administration of. $56 million of that is for technical support and analysis of the AHEAD model. So the first year, we're going to be assessing whether or not this model is going to work for Georgia. So they're going to be gathering data from Georgia hospitals and deciding whether or not this is going to be something that is going to be beneficial or not, or at least how beneficial. It seems from the feedback I'm getting, they're pretty intent that this is what they're going to do. A few questions from us are, well, CMS has already come out and said we're only going to allow 2 states to enter this model this year. So what happens if we don't get selected? We've invested, $76 million of this funding into moving hospitals to this program. And we really don't know what happens if we don't get selected. DCH feels very confident about their position in being selected for this model. But the other bucket of funds are earmarked for very specific things around the state, most of them to be distributed in the form of grant funding. The largest bucket of funding is helping to open up GME seats. So there is a lot of funding that is going into advancing GME seats for GME programs that have a rural connection, that require a rural rotation, something to that effect to help incentivize providers to at least gain experience in a rural environment, or at the very, or on the larger scale to um, hopefully have them take jobs in rural areas. Beneath that is a very specific and prescriptive bucket of funds for things like emergency preparedness for hospitals to increase emergency infrastructure. Mental health is a big focus of this bill, and expanding mental health access. Telemedicine is a big component. A very large pool of funds is being allocated towards mobile care pods. We don't exactly know what that looks like, but the way it's described is effectively a kissing booth that you go and sit in, and it can be in any location, but where you go and sit in a booth and push a button and get connected to a family physician through telemedicine and have your visit in said pod. So I will say frankly, that's not tremendously beneficial for me and my community when we have a population of 27,000, but a primary care base of 29 physicians. We're well supported with physicians in my area. We've got a really strong physician network. So it's still a little bit unclear as to how some of these decisions were made, as to what this funding was going to be going for, but we're kind of rolling with the punches as we do in rural healthcare and just adapting and figuring out how we can best capitalize on this.
So you and I met down at the Capitol. So can you tell me how much time do you have to spend at the Capitol lobbying for your hospital?
So, more than I would like to. I'm not a politician, and I'm a very operational leader. I like to be hands-on. I round in all of our hospital units every single day. And when I am not at the hospital, I am usually at the Capitol, which is generally about 2 weeks out of the year while session is open that I'm down there. And more recently in DC, advocating for my hospital in DC. What we saw last year with the big beautiful bill was a need to not just rely on lobbyists. Um, our legislators are more interested in hearing from the people that actually influence votes that are in their constituency and actually can influence their community. So I have to spend a lot of time at the Capitol, and you and I met on Tort Reform Day, the introduction of House Bill 6 or Senate Bill 68 and 69 last year. We were strongly in support of that legislation, and we're glad to see it passed. It got a little bit watered down by the end, but with this piece of legislation that we're talking about with the Great Health Program, we're going to be very present, making sure that we understand where this funding is going first and foremost, and then educating our legislators as to where it's going as well.
Okay, so what is the best part of your job?
So again, I like to say I round in all of our departments every single day, and I like to see the work that is going on around me. I'm not a clinician, and I don't have to be a clinician, but I love seeing the impact that we're having on patient care. And I'd just like to be a part of that. And I ingrain myself very heavily into it. I want people to make sure that they know that there's not a divide between administration and clinical care. We had two emergency weather events over the last few weeks, and we had to shelter staff in place. We had an ice storm 3 weeks ago, followed the very next weekend by a snowstorm, and that requires us to shelter staff in place. And anytime we do that, I'm going to be sheltered there with them. So that is something that I just want to bridge that gap. I want to make sure that people know that they're well supported, that they're appreciated, and I get to see the impact that they have. And that's the best part of my job is just watching what the people do around me.
You do have some dedicated staff that are really very serious about doing a good job taking care of the people in their community, and I think that that's a real plus. Um, I don't know what you think is the worst part of your job besides going to the Capitol all the time and the lobbying, but I guess there's pluses and minuses to the lobbying.
It's up there with the worst part of my job. I will say it's frustrating to have a conversation with someone where you hear that, yeah, I hear you, and we're going to do something about this challenge that you're talking about, or we're going to take your feedback and we're going to act upon it. And then you see something contradictory to it. And that's the world of politics, and I don't like being very close to it. But outside of that, I have a 21-month-old that is asleep downstairs beneath me, and I am generally working at least 60 hours a week, and I would much rather be spending time with him on some days. And that's probably the worst part is this is a time-consuming job, and I'm away from my family a lot as a result of it, but it's worth it, and my family is very understanding. Um, but that's those are the things that I think the most about the worst part of the job.
Okay. So we're going to go to questions now. If anybody that's listening has some questions about how things are changing at Georgia hospitals based on what's happening and what DCH is doing, I don't know if we'll have the answers because we don't really know how it's all going to work, but I think things are going to be changing and they're one other thing before we go to questions, Donnie. So, Van, we were talking about staffing, and so I mean, there's programs or situations to try to get physicians to rural health, but what about the rest of the staff, like X-ray techs or nurses or patient care techs? I mean, how do you attract those people?
Well, I'll start by saying that I'm really glad to see the state putting a lot of energy around graduate medical education. We are nothing if we don't have physicians, so I'm really glad to see that there has been so much emphasis. I really think that Dr. Burke being in his role is going to have a major impact on that. And I think that we'll also see an expanded focus on some of those supportive clinical positions. But those are some of the harder positions to fill right now. I've been recruiting for an SLP for 5 years now. Um, and it's really hard to get that talent in rural areas specifically. But if you think about hospital medicine, a lot of speech therapists want to go into education or to work with younger, with children. And what we need them for in our community is for helping with stroke patients and swallow studies and long-term care and those things that really aren't glamorous. But we need them, and it's hard to find. And there's not a lot of energy or at least discussion going into advancing those types of programs. And you mentioned X-ray techs. Um, we expanded MRI coverage to weekends, but that was very, very difficult for us to do because it took a long time for us to hire one single MRI tech. And it's really difficult to cultivate that workforce in rural communities, and very often we have to break out our checkbook. Fortunately, as we all know, that rural hospitals are just flush with cash, and that's easy for us to do. But it does present a challenge, especially in a market like mine, where you can get to three other hospitals. Granted, all three are a little bit smaller than ours, but within about 20 minutes, and to major health systems in Athens and Gainesville and Greenville and Anderson within an hour. It's a competitive market as well, and that pool of talent is is a very competitive pool. So I think that I would like to see some more emphasis and focus on some of those supportive positions, complementing that energy that's surrounding GME right now.
But you did win an award, right? As one of the small hospital awards. Was that 2024?
We did, yeah.
Mhm.
2024, we were Georgia Trend Magazine issues a production of the highest ranked hospitals by category as ranked by CMS. And we achieved the number one small hospital, small being 100 beds or less, in 2024. And we're glad to hold that achievement. And that's great. The things that are more impactful to me are the things that we've been able to accomplish through accrediting bodies with becoming a stroke center and becoming a cardiac care center. And we're a center of excellence in orthopedic surgery. And all of those things are the more substantial awards to me.
Right. And those are things that are going to attract patients to come to that hospital, as you're saying, rather to you in their community rather than going out to some of these other communities around. Okay, Linda, do we have any questions in the chat box?
Um, Currently there's nothing in the chat, but if someone would like to raise their hand or unmute themselves, please feel free.
It'd be really nice to think that we're being so clear they have no questions. I mean, that's pretty good. Or maybe it's just so confusing with this new bill and what's going to happen, which we don't really know, but it is going to be something that's going to change how the payment goes to your hospital and to other small hospitals. I think the concepts that you've worked on is trying to partner with other places that have a like your stroke center and your cardiac. I mean, I think that that's helpful. But, so you have helicopter and ambulance transport then for people that do have to be sent somewhere else, but you'll be able to handle more of them right there in house.
Yeah, I think it's really important that we understand that there is a scope that we can accomplish and a scope that we don't need to accomplish.
Right.
And you walk a fine line of getting too far out over your skis. And I want to make sure that we're always practicing safe medicine.
Right.
I see a
Right.
few hands up as well. So,
Yeah.
Dr.
Donnie?
Clark?
Hi, Bill Clark. I practice ophthalmology in rural southeast Georgia in Waycross, and I'm actually the only ophthalmologist that wakes up in the entire rural southeastern quadrant of Georgia. And I'm trying to figure out how the new payment model would affect my practice as a solo practitioner. I mean, Medicaid and Medicare already are really terrible payers for us, even as, on a per event basis. What should I anticipate that model would be like down here?
so I will qualify this with saying that I do not represent DCH, who is in control of this, but I would also say that this is first and foremost a voluntary opt-in. Um, no healthcare provider has to make this transition. Georgia, with this program, is trying to do a lot to incentivize providers to opt in. And they're doing that in the form of saying, well, we've got all this pool of funds that we're going to issue in the form of grant funding, and we're going to give priority to those organizations that opt in to this model, to receive this other pool of funding. So you don't have to do it. Um, I would also say, as if you're a solo practitioner, then I wouldn't anticipate any change at all. This a head model, as I understand it, is intended more to focus on hospitals. And so I would say if you're practicing as a solo practitioner, you wouldn't really expect to see anything at all. This is on facility-based reimbursement.
Okay, I do all my surgery in the hospital, but my surgery.
It would depend on your relationship with the hospital. And I would say that there are certainly different models for how hospitals work with physicians, and some of that can be reimbursement based. And there's going to be good and bad to this model. The good is that you will have clarity as a hospital as to what amount of money you're going to get paid in a month. And for us, that can be a bit of a challenge to predict and forecast when you're at the whims of whenever some payer wants to issue payment. We don't have any kind of an idea at all as to how much money this is going to represent for rural hospitals. Is it more? Is it less? We have no idea.
Thank you.
Yeah, glad to
Dr.
answer.
Wilmer?
Charles, you have something to say? You have your hand up.
Your mic is muted though.
Mhm.
Well, while we are waiting for Dr. Wilmer, there was a question in the chat from Dr. William Hollows. How does rural hospitals being acquired by larger health systems help or hurt the future of rural hospitals' growth or pose an existential threat?
So, great question. There are pros and there are cons. Consolidation is something that we saw kind of level out between 2021 and 2025, and now it's starting to pick up momentum again, and you're starting to see some more movement in the M&A market. The good is that systems have generally larger cash coffers than an independent standalone hospital that allows them greater opportunity to improve capital infrastructure, to funnel specialty services to these hospitals. Uh, Cash is difficult to come by in a rural standalone hospital, and that's what it boils down to. With membership and a larger system, it does present greater financial opportunity to improve your infrastructure. The bad is that that doesn't always happen, and that doesn't always take shape. Sometimes it can look like a larger system acquires a hospital that is competing with their hub hospital, and thusly they're able to then have greater control as to the direction of where patients are transferred. So that's the bad part of it. That's not always a bad thing to transfer a patient, but it can degrade the services that might exist in a rural market. If a larger system sees that as too expensive to keep in a rural market, then they might close services at a greater rate than the independent hospital that knows they have a reputation that they have to live on. The other thing is that it depends on how close that hospital system is to its tertiary care center. And is that the closest tertiary care center? And thusly, you have the moral question of, is the patient actually getting transferred, if they have to get transferred, to the closest appropriate receiving facility? So that's the good and the bad of the future of healthcare. I will say that it is constantly on the minds of most rural hospital administrators as to, do we remain independent? Do we seek consolidation? Because you do walk a tightrope.
All right,
Dr.
I think
Wilmer?
I'm back.
Mhm.
Yes. So number one, you obviously know great talent because you have.
Oh, Dr. Wilmer, you just muted yourself.
All right, can you hear me now?
Yes.
Yes, sir.
Yes.
I'm hiding from the deer, so I'm gonna get run over. So number one, you have a good judgment because you have great talent in Deborah Martin. So I'm glad she's been in your hospital doing great surgeries. Second of all, maternal mortality, working with DCH and Department of Public Health. How is that going for you, and what do you see we need to do to make that number better?
So Georgia ranks last or nearly last in so many different healthcare categories. Um, and I think that you can look at so many different things between maternal and fetal health, and expanding access to these labor and delivery deserts that exist particularly and most abundantly in the southwest part of the state. But you also have an aging population in your rural communities specifically. And I think it's harder to expand access to care when medicine has become so subspecialized. And the traditional methodology of having an internist or a hospitalist is not valid, especially for physicians that are coming out of training right now. When you're used to having every single subspecialty immediately available and in-house, ready to come to support you as an internist. So I think that a lot of work is going to have to be done in figuring out how you expand access to subspecialty medicine in rural areas. Telemedicine can help in some aspects, but the areas that we find it to be most effective are certainly in the areas where patients aren't going to require some sort of advanced procedure. And telemedicine is not going to bridge that gap for us, and there has to be another solution. But unfortunately, what we keep hearing is telemedicine is the solution. We've got to expand telemedicine. It is helpful. Don't hear me that I'm saying it's not, but you're not going to address those outlier rates of mortality. If you look at things like cardiovascular disease, um, diabetes, hypertension, all of these things that are so prevalent in rural populations, there's only so much that telemedicine is going to be able to do. And there is not good discussion around what is being done to expand beyond telemedicine.
I think Department of Public Health was making house calls. Are they up in your area doing that?
I'm not sure if they're making house calls, house calls to individuals that live in the community.
Yeah. So pregnant women who they think are at risk, they're
Mhm.
actually making visits to their homes.
Not to my knowledge in our area. That could be the case. Unfortunately, healthcare remains a pretty siloed industry that we work in, and sometimes one hand doesn't know what the other's doing. So I won't say they're not, but they're not to my knowledge.
Okay. All right. Looks like an opportunity for us. All
For
right. Thank
sure.
you.
Yes, sir. Thank you.
We have another question in the chat from Dr. Jorge Alfredo. With present Medicare, Medicaid payment models and increased HMO entities, how have you been able to increase revenues?
Simply by increasing volume. When I became the CEO, we had developed a reputation that was not good, and we had a very significant problem with outmigration, patients choosing to bypass our facility. Now, part of that was self-inflicted by simply not having the services that they needed, and part of it was by just not being engaged with the community outright for the things that we did have. So I think you've got to be a partner with your community and expand in the right areas. For us, yeah, Medicare is not our best payer, but we were a hospital that had a negative operating margin. We were losing around $8 million a year just 5 years ago. Our profit last year was modest at $1.9 million, but I will gladly accept a 4% operating margin, and most hospitals would. We just set the bar really low for ourselves, and we had to challenge that reputation that we had established. We had to change the narrative. We had to actually put things in place that allowed patients to use our hospital, and that's how we've been able to increase our margins, even though we're about 55% government payer, Medicare, Medicaid combined. They're not great payers, which requires us to be very cost conscious. And that does prohibit us from being able to do all the things we want to do. But that's the windy answer to the question. It's volume solves all problems, right? Um, Not exactly true, but community hospitals fail when they fail to meet the needs of their community, and we were failing.
Right, because some of the people have talked to me about the fact that how many of the patients used to be transferred compared to now, and you already mentioned that tonight. So I think the fact that you could keep more of the patients at your hospital and take care of them because they want to stay at your hospital, they don't want to be transferred if they're from. I think that's been a huge step forward.
I worked with the both the March of Dimes and the Ronald McDonald House when I was in Savannah, which is my hometown, and particularly with the Ronald McDonald House, I got to see the impact that it has when someone has to drive a long distance to visit a loved one in a hospital. And that is why it's so important for us to make sure that we're keeping healthcare as close to home as we possibly can.
Are there any other questions in the chat or anyone else in the audience?
I saw Dr. Register asked when it starts. So
Yeah.
Yes, sorry about that, Dr. Register.
it's okay. A recent introductee of mine who trained with one of our other surgeons, and it's good to hear from you, Dr. Register. Um, so this year is going to be an assessment year where the state figures out if this is going to work or not. We then submit our proposal to CMS. It would begin if we are selected in 2028.
Yeah, so right now it's in the planning stages and the lead up to this change, but you still have to be thinking ahead. Yep.
That's right. Yeah, I mean, this funding is here now, and the funding that we've received this year must be spent by October. So we've, I'm sure we'll do a fine job of spending that money in short order. Um, but the funding that we're spending now is not actually going to go into the AHEAD model. It's trying to incentivize and prepare the state to understand whether or not this is the right path.
That's a good question. Anybody else? Well, appreciate all of you taking your time come tonight. And Van, we really appreciate you coming and talking to us and engaging. And what we're starting to talk about what's going on out in the state in rural healthcare. The legislature is certainly focused on it. As a medical society, we cover the entire state, even though our largest component is Atlanta. But we're trying to look outside to rural medicine, and that's one of the big things I'm wanting to do during my presidency. And I don't know if you've had any feedback from any of your physicians about getting their safe haven memberships. Have anybody said anything to you about that?
I wish I could say they have. They have not, but I know in their hearts they're appreciative.
Okay. I don't know. I do know that some people that have received them are using them. Um, Mr. Bonfini has the records on that, but we are asking the legislature to renew their commitment and fund so that we can continue and renew all our memberships because we have like 1,700 people now, physicians out in rural Georgia that have been given memberships, and we want to continue. And I think that if they start using them, they'll appreciate it even more.
Certainly. Yeah, we certainly appreciate the effort. I know the impact that it can have, and I just hope that physicians do choose to take advantage of that.
Yeah, Dr. Cecil Brown thought it was a good idea that perhaps it was going to help out. So we'll see what happens. Time will tell.
Thank you.
Thank you.
Thank you for everybody being on tonight. Also, the AMWA is having their meeting with Dr. Teresa Rohr-Kirchgraber, as well as just don't forget to sign up for a legislative seminar. You can find it on the main page at MAG. And other than that, though, everybody have a great evening. Van, thank you for joining us, and thank you, Dr. Martin, for running Martin's Minutes.
Thanks, Donnie.
And
Great
bye, everybody.
program.
Good night. Thanks, Van.